O'Connor from AAAS. Today I'm broadcasting from my home in Washington, D.C. Eventually, there will be a coronavirus vaccine, but it will be a long time before there's enough for everyone. How should we choose who gets it and when? How do we distribute vaccines to countries that don't have the resources to make their own? To answer these questions, Zeke Emanuel, Govind Prasad, Lisa Herzog, and others on a global team of ethicists developed the FAIR priority model, a framework for distributing vaccines to countries ethically and effectively. With me today to discuss their model is Zeke Emanuel. Zeke is an oncologist, bioethicist, and professor at the University of Pennsylvania's Perelman School of Medicine. He was a health policy advisor for the Obama administration. Zeke, welcome.
Nice to be here. Thank you for having us. Great,
thanks. Zeke, I was listening to an interview with you. I think it was done in April, and you for the Vox podcast today explained, and you mentioned that I think you were losing sleep over the testing situation. Are you sleeping?
No, the testing situation is pretty bad. We still don't have those long expected point of care solutions where people can, we can have millions of people doing it every day, but it's only one component of what has been frankly screwed up in the American response compared to every other country. It's testing, it's PPE, it's vaccines, it's coordination of all the public health measures across states. We just have not responded very well, and that is one reason we're leading the world in terms of mortality from COVID.
Well, we'll get into that. Also with us today is Govind Prasad, an assistant professor at the University of Denver Sturm College of Law. Welcome, Govind.
Hi, well, welcome. It's great to be here.
Govind, when you published this paper on the FAIR priority model, you tweeted, "Our piece on vaccine allocation is now out in Science Magazine. All those 7 a.m. Mountain Time Zoom calls paid off." Are you sleeping, Govind?
I am sleeping minimally, in part because I have a almost 1 month old baby, but it's nice to feel like you're able to do something to contribute globally, and it was a really exciting experience to be able to hear the ideas of so many different folks thinking about these issues from different countries, different backgrounds.
Great, yeah, can't wait to hear more about it. Lisa Herzog is a professor of philosophy at the University of Groningen in the Netherlands. Welcome, Lisa.
Hi, thanks for having me.
Lisa, earlier I was reading that some of your work is on why workplaces aren't more democratic, like why we don't vote for our bosses. Is that right? Are there workplaces that do that?
Yeah, well, sort of. I mean, Germany has co-determination, which isn't perfect workplace democracy, but it's far more democratic than in the US system. And during the COVID crisis, there was actually a big manifesto about the need to democratize work, which more than 3,000 scientists worldwide signed, because this crisis has shown, among other things, that there are all these workers out there that really keep our societies going and that have very little say in how their workplaces are run in most societies.
Oh, well, my boss is almost certainly watching this today, so let's not talk too much about that.
What I wanted to talk about really well, even in the U.S. Interesting, better than a lot of things. Anyway.
So getting into your paper in Science, it's called An Ethical Framework for Global Vaccine Allocation. And one of the things I wanted to talk about was, why do we need an ethical framework? There are a lot of medications, a lot of treatments that we don't really, or at least that I think most people are aware of, have an ethical framework for who gets it. It's often kind of first come, first serve, or whoever has the insurance. So Lisa, maybe you can start. What is special about this situation that requires this kind of response?
Well, it's a global pandemic, as we all know, and there are huge inequalities in the background that at the moment seem to suggest that if nothing is done to coordinate international action, there will be what's now being called vaccine nationalism. So all rich countries at least will try to get as much vaccine doses as they can. And that's going to be neither fair nor efficient, because it will probably prolong the global pandemic, and it will lead to far more preventable death than if there is international cooperation, and if one really thinks about reasonable, justifiable principles for who should get the doses in what order. Because it's a temporal problem. Eventually, hopefully, everyone will get it, but the question is who gets it at what point in time.
Mm-hmm. Yeah, and that notion of vaccine nationalism, it seems pretty pervasive. There was even some discussion in the comments of this post, people kind of getting at that idea, and I want to get into that a little later. But for this framework, you talk about 3 fundamental values that it's based on. Govind, could you kind of take us through each of those and why you chose them?
Sure. So the 3 fundamental values that we focused on, that we sort of came up with by thinking about which values get endorsed across a variety of different frameworks, are first the value that we called benefiting people and limiting harm. So this is a value about doing good, making sure that the distribution of a COVID-19 vaccine helps to alleviate some of the really serious harms that we're seeing, harms like deaths, other long-term serious illnesses, and then obviously the indirect effects as well that we're seeing in terms of poverty, unemployment, people not being able to go to school, that are both bad in themselves and then can also cause health harms. That's the first fundamental value. The second one is prioritizing disadvantaged recipients of the vaccine. And that's, again, something that we see as a consensus value across different frameworks for global health. You care about benefiting people and limiting harms, but also about benefiting people who beforehand were more disadvantaged. And then the third part of the framework is the value that we call equal moral concern, which essentially says unless you're either benefiting people and limiting harm or you're prioritizing the disadvantaged, you shouldn't consider sort of other factors arbitrarily that aren't relevant to pursuing those goals. So you should show equal moral concern for people with respect to all the other kinds of factors that might be used.
And now, Zeke, you've written, I have a paper here by you from 2006 about a potential flu vaccine. And I'm wondering, what is the history of trying to solve this kind of vaccine distribution problem, and what prior frameworks did you draw to develop what you have here?
Colin, that paper from 2006, which started me really thinking about these allocation of very scarce resources, like flu vaccine in a pandemic, like organs for transplantation, livers or hearts or kidneys, and now a vaccine for coronavirus. That paper in 2006 was about distribution inside the United States. How do we decide which citizens should get it? And by the way, that discussion is alive this minute in the United States, where we're considering, okay, we're going to have, call it 30 million doses once a vaccine is approved. Who is in the top priority list? Who's in tier 2? Who's in tier 3? And so that's a very live discussion. But the issue that our paper in Science addressed is a much more complicated issue, if you can believe it, which is an issue of how do we distribute the scarce resources among countries? Not only does it take public health into account and epidemiology inside a country and the political system in a country, it has to take international relations, economic relations into account. And to be honest, when we began this in March and April, we couldn't find a single paper that actually addressed this issue in the biomedical literature, Science, New England Journal, Lancet. It is so hard, people have avoided it like the plague. So we thought, well, who better to address it than ethicists from a number of countries, public health people from a number of countries, both rich and poor countries, to really see if we could make progress. And from a diversity of perspectives, not all of these people, share the same philosophical orientation. So that's why this paper is so different. Subsequently, as you pointed out, the WHO has come out with the view, and there may be one or two other views that evolve.
Yeah, I want to get into some of the competing frameworks, but I also wanted to return back to what Lisa was talking about earlier about vaccine nationalism, which I guess is one of these competing ideas. There was some discussion even on our Facebook page today, and I think it's maybe a reasonable kind of first gut reaction that whatever country makes the vaccine should get it. Lisa, can you talk about that notion of vaccine nationalism a bit and how it plays into what you've developed here?
Well, we sort of reject it, at least we say it's very limited. There was actually quite a bit of discussion about this in the group, and there are reasonable disagreements about how far one can go. I mean, intuitively, you could say that it's a very natural thing that a government would try to get as much vaccines for their people as they can. I mean, they are elected, if they are elected, to look after the welfare of the country. And then if you have a vaccine producer in your own territory, that seems to be another reason. But actually, when you think a bit more about it, which country will have vaccines produced first is really a matter of luck. And also, this is something that's not in the paper, but arguably there are also quite a lot of historical injustices that have influenced where vaccine production actually takes place and where it doesn't take place. So that shouldn't be a determining factor. And if you just go and let countries buy doses, you get into, you know, a total sort of Darwinian law of the greatest purchasing power, but it has nothing to do with fairness or efficiency.
Can I come in here, Colin? And just sure. So this is actually one point in which we had a lot of disagreement in the group. There are some people who think vaccine nationalism is more justified, and there are people who think, you know, country borders shouldn't matter at all in terms of promoting the welfare of people. But one of the things that we agreed across all people who were on the paper is that even if vaccine nationalism can be justified, it's limited. It's not absolute. And let me give you an example I just heard. I was interviewed today by the Canadian Broadcast Company, and the interviewer said that in Canada, they have pre-orders, options on orders of 230 million vaccine doses. And I'm like, wait a second, that's almost 8 times the population of Canada. That seems unethical because that's a kind of hoarding by a country. As I understand it, Britain has the most vaccine pre-orders per capita of any country in the world. And that, again, even more than Canada, that again seems unethical to everyone. It's unjustifiable that you should have that much for your population. There's a limit to how much nationalism you can have, how much priority you can give to your own kind. And that was a very important conclusion of the paper.
Right. The paper mentions this kind of upper limit of, you know, you can give vaccines to your own population until you reach this transmission rate of 1. Zeke, can you explain what that number means to our viewers?
Well, above 1, if you have a transmission rate above 1, then the disease is growing. The number of cases is going to go up. If you have a transmission rate below 1, it's going to die out because you're transmitting to fewer than your cells and you're on the downward side. And we thought that was a good cutoff. A way to think about it is that you have a low level of cases and a downward slope of, so the number of cases is going down, not up. And I think that's a way that, you know, once you're in that position, you really shouldn't be taking more vaccines from other countries where we know there could be a high rate of prevalence of the virus and it could be going up. That's a time where you do have to recognize the vaccine can do more good in another country.
Mm. And the paper mentions distributing the potential vaccine in 3 different phases. And Govind, can you tell me what those phases are, how you arrived at them, what the different kind of ethical considerations are at each step?
Sure. So something that I think is distinctive about this COVID-19 vaccine scarcity compared to other scarce medical resources we might think about is that we're expecting the availability of the vaccine to get better over time. So you're starting out with very little, and then over time, you're getting more and more. And so the question is not so much who will get a vaccine ever, but who will get a vaccine first, which countries will get vaccines earliest on. And so we thought about the three phases in terms of which outcomes were both the most serious and the most irreversible, such that the only or the best way of preventing those bad outcomes was to use COVID-19 vaccine early on to prevent them. And so phase one, we really focus on preventing premature deaths, because we suggest that that is probably the most irreversible and most serious outcome. And the metric that we suggest integrates preventing harm and prioritizing disadvantaged countries. Then in phase two, we move to outcomes that aren't death, but are serious outcomes like long-term illness, and then also outcomes like poverty and economic decline. And then in the last phase, when we expect that you would have more vaccine and the impact of the pandemic is less, then you turn to the sort of broader goal of ending disease transmission. So this is really developed in the context of a dynamic pandemic where you're expecting vaccine production to ramp up over time.
Mm-hmm. Now, I just want to remind anyone watching, so I'm speaking with Zeke Emanuel, Govind Prasad, and Lisa Herzog about their framework for distributing a coronavirus vaccine around the globe. If you have any questions, feel free to leave them in the comments. We're collecting them as we go. I've got a few here in the hopper already. Lisa, I wanted to ask you, this framework targets countries that are doing very poorly. And I think that one critique of it might be that, are those countries being rewarded for not handling this well? And are the countries that have handled it well being punished? And so how does this model address that?
Well, in a way it doesn't, because it's based on the assumption that all human lives worldwide matter equally, and people can only, to a very limited extent, if at all, be held responsible for how their governments manage these crises. And often those who are most disadvantaged in those countries are least likely to have had influence on the government. This idea that you would somehow punish governments in order to hold them accountable, that seems to be using the population, the individual human beings, as a means in order to, to give a lesson to the governments, and that would seem inappropriate. I mean, there are other policy tools that you can use for international, expressions of disapproval, but a vaccine shouldn't be used for that, because that's really not the purpose of a vaccine. The purpose is to save lives, to prevent harm. And so we are not really accepting this as a charge, because it would contradict the very point of what a vaccine is all about.
Mm-hmm. And there does seem to be some room here for if a country has been breaking its back to prevent the spread and it's been hurting its economy, that their countries whose economies have been damaged are prioritized as well. Is that right?
Well, those where the economy has been damaged, they wouldn't be prioritized in the first phase. But in the second phase, when the focus includes socioeconomic issues, then there's a poverty index that comes in, and loss of GDP, or national product. And there, if there's a poor country where there has been a lot of economic damage, that would put them higher on the list in the second phase. And that seems appropriate, because it's really worse for them than for others. So at that point, they should prioritize, yes.
Govind, do you have
Colin,
something
I think one point here to elaborate something that Lisa mentioned, but I think maybe, what we really care about is individual people in their lives and how well their lives go. We distribute vaccine to countries because that's the mechanism we have. But in this case, countries are intermediaries. They're not the ultimate beneficiary. And to hold individual Americans responsible for Donald Trump's performance on, coordinating the response to the pandemic, and to say they don't get a vaccine because he hasn't done as well as he should have, that doesn't seem to hold individual welfare at its top. That, again, has to be our focus all the time. How can we benefit individuals?
Govind, did you have something?
Yeah, this is, I think, a more minor point, but in thinking about phase 2, where you're thinking about the economic impact, it's important to remember, as Lisa said, what we're trying to use as a vaccine to benefit people. And so in some cases, you might have countries that have been hit hard economically where the vaccine could have economic benefits, and it makes sense to consider that. In other cases, there might be means other than COVID-19 vaccines that will be more effective at alleviating long-term economic effects. So it's important to remember the tool we're talking about here in the paper is a COVID-19 vaccine. That can't be used to address every sort of problem of international harm or disadvantage. It needs to be used where the vaccine can be, the harm is of the kind that a vaccine can prevent, as opposed to the kind that can be addressed through money or infrastructure or other kinds of interventions.
So what I'm hearing mostly is a population shouldn't be punished for kind of the decisions or the happenstance of however their country had to deal with it. We have a couple questions coming in on our Facebook page. There's one from Olivia Hasaya. I hope I'm pronouncing your last name right there, Olivia. About how do we decide even which countries get these vaccines first? What kind of mechanism is in place for this framework to be implemented? And who, I guess, is this article targeted to? Who do you want to read it?
Well, look, it's targeted to the three big decision makers. Those are leaders of countries, and in particular, leaders of the most important world powers that have the biggest influence. The G7 that can alter things, signatories to the COVAX facility. It's also targeted to the leaders of the COVAX facility because they are going to help distribute the vaccine, and they have to have a framework, an ethical framework. And last but not least, it's also targeted at the vaccine manufacturers. Many of them have committed themselves to, broad, equitable distribution of a vaccine. That's the phraseology of the CEO of AstraZeneca. They need a framework for what's an equitable distribution. And prior to our offering, there really wasn't a framework for what constituted an equitable distribution. So we were helping them give it with a framework. Now, we don't have a world government, so it's not like there's a world parliament we can appeal to. This is, you might say a little messy, but this is kind of like standard fare in international relations. And what we're hoping is that the ideas we've developed become the framework that people can affirm as the ethical approach. And we think it's going to be a very efficient approach in terms of saving lives.
So there is a market for this kind of thing. It seems like a lot of companies have signed on, or governments have.
If I could add, I mean, this is an interesting question of what are the responsibilities of vaccine producers, and we're hoping to produce a follow-up paper to think about that in particular, because that's, in a way, that's also the other side of this national hoarding, that all these companies are now at the moment entering into contracts with rich countries and promising that a certain percentage of doses will go to them. And of course, that also raises all kinds of questions of whether it's legitimate to maximize profits when it comes to COVID vaccines.
Now, kind of the biggest question that I'm getting from Facebook right now is, where are we with the vaccine? And I can understand why people are asking that. Zeke, do you know what's the latest news, and when can we hope to put a framework like this to work?
Well, at the moment we have a number of vaccines in phase 3 trial. We just had Johnson & Johnson, I think a week ago, maybe a little more, enter phase 3 with its vaccine. We still don't have a result. On October 22nd, the advisory committee at the FDA for vaccines is supposed to meet. It's unclear whether they'll have data to review. They'll review where the various studies are. But if you listen to, certainly Operation Warp Speed and other people in the U.S. government, towards the end of the year, maybe early 2021, we will have data, and that'll go to the FDA to review. That's certainly for the United States. We're not the only group evaluating it. Russia has its own vaccine out there. China has several vaccines that it's testing. It's suffice it to say whether they both countries have been, I would say, rapidly approved after phase 2 without a validation of its real effectiveness in preventing coronavirus infection. They're now pursuing legitimate phase 3 trials. We're not going to have something until the end of the year, most likely, where this framework could influence it. But again, you can't wait till you have a vaccine to adopt the framework. You have to begin doing that work now. And that's why we work very, very hard, as Govind said, every morning, every Monday morning for several months to really pound this out and to create this, what we think is an ethically justifiable and very practical approach.
It seems like there was a lot of work put into, exactly that, not just kind of hammering out the, getting the most ethical thing imaginable, but also making it practical. And Govind, maybe you could talk a bit about how this framework might be applicable to future pandemics or other healthcare issues.
Sure. So one thing I would actually caution against is that with any pandemic or any healthcare issue, you have to consider some people, I think scientists call it the sort of personality of the pandemic, the distinctive ways in which it might harm some countries more than others, or, for example, whether it might require only one vaccine, or whether you might need to have regular booster doses or not. At the same time, I think the way that it would influence thinking about other distribution issues is that I think the principles benefiting people and preventing harm, prioritizing the disadvantaged, equal concern, those are ethical values that I think hold true across a variety of different pandemics. The question of how to think about, and for any pandemic where you're expecting production to increase over time, something like phases make a lot of sense. In terms of the specific metrics you would use and how to implement those, that would be something where you would need to have information that's going to vary from context to context about what sorts of outcomes the pandemic or the shortage is causing. Not every health problem causes the same kind of, for instance, economic devastation by requiring measures that then have effects on, for instance, in developing countries, you're doing the important work of preventing coronavirus, but you're also concerned about if you're getting drop-offs in efforts to prevent malaria or efforts to do childhood immunizations. And needing to factor that in for a transmissible disease might be different than thinking about distributing some other kind of scarce intervention between countries.
Mm-hmm. So we have tons of questions coming in. We only have a few minutes left of time, but there are a few I want to get to here. Caroline Brackett asks, since there will be multiple different vaccines produced by various companies, will there be different types of vaccines administered in different areas, depending on production capability? And I might even add, depending on the individual kind of effects of the vaccine or how it's administered. Zeke, you have something to say about that?
Colin, I think that incredibly perceptive question, which is, it's complicated enough to figure out how to put a vaccine across all countries. And as Caroline has pointed out, it's going to be even more complicated in this case because some vaccines might work better in elderly people. Some vaccines might work better in younger people. Some vaccines might have a longer duration of action rather than a shorter duration of action. So you may actually be having, multiple allocation processes across time targeted at different segments of population. But the fact of the matter is, at least early on, call it the first 6 or 8 months, we won't not necessarily know the answers to those questions until we see how the vaccine behaves when it's given to a larger population. And it's safe to say, I think this is accurate still to today, no vaccine has begun clinical trials, phase 3 clinical trials in children. And so that also is going to complicate matters. So this is you have to solve multiple distribution problems all at the same time. And that, I think, does add complexity to this problem. I would go back to what Govind emphasized, which is we think we've given the right moral framework, the best moral framework with the using Occam's razor, the fewest ethical principles, but the ethical principles that matter. And that will be universal. That will travel even inside a country. If we look at the distribution inside the United States, that ethical framework, those principles should hold. It's then which metrics do you use, et cetera, that have to be built anew for each pandemic.
Lisa, did you have something to add?
No, I was just nodding.
Okay. So I also saw Govind and Zeke, you had a more recent paper about distribution within, I think the US specifically, but possibly within any country. Govind, could you talk a little bit about that? Is that kind of the same kind of rubric here?
So I think exactly as Zeke said, the ethical values that are underlying that framework are the same ideas of benefiting people and preventing harm, equal concern, and prioritizing disadvantaged groups. At the same time, we have different recommendations inside the US than we would have globally, because you're looking at different, the US population is not a mirror of the world. So in our paper in JAMA, we say it makes good sense to prioritize health workers because that enables people going back into healthcare facilities without being scared of getting COVID-19, being able to go in to get things like, again, dialysis, childhood immunizations, all sorts of other things. And within the US, I think that makes a lot of sense. But a concern that I would have about saying you do that globally, which the WHO has talked about, is that globally, countries differ a lot in terms of whether they have healthcare professionals. And so a concern I would have about saying you prioritize healthcare professionals is in countries where there are not very many of them, that's going to have bad effect. It's going to be unfair. They're going to be hit twice, both by having fewer healthcare professionals so they can't get those services first, and then getting fewer vaccines for their population. So what might be fair within the US might not be fair in choosing between countries.
I see. So it might seem intuitive to target healthcare workers and the elderly, but there are vulnerable countries that don't have many of either of those things. There's another question on our Facebook from Anna Kropornica that I'd like to direct towards Lisa. This is kind of getting back to the vaccine nationalism idea. She's asking, how does government funding in the case of the US, or in the case of the US, third-party management firm contracts affect the distribution? So, if our government's money is going towards a vaccine, would that add to the argument that the vaccine should go to the citizens who paid for it? Or is that not happening here?
That's again this question of vaccine nationalism, on which there has been some disagreement in the group, and where we agreed that there is a limit. For the basic ethical principles, it shouldn't matter, because as we emphasize, it's really about saving lives. Realistically, do we expect that it will not matter at all? Probably not. Mm-hmm. But and I got this question a lot from journalists in Europe saying, oh, our governments are paying so much for this, so why shouldn't the citizens expect that they will get the money first? The vaccines first. But still, there will be some points where, even if that scenario happens, which would be bad, but is not totally unrealistic, there will be points in time when these Western countries have had their citizens vaccinated, and then there will be another distribution question, and then the framework might still be useful. But from the ethical perspective, that shouldn't really be decisive.
So I think we're running to the end of our time here. So if you've been with us this whole time, this has been Zeke Emanuel, Govind Prasad, and Lisa Herzog about ethically distributing a coronavirus vaccine around the globe. Before we go, maybe you could each just tell me when there's a vaccine and we can leave our homes again, where's the first place you're going to go? Govind.
The first place, I mean, where I would really like to go is I would like for my new 1-month-old baby to be able to see his grandparents. And so I think if that's not the first place that I say I'm going to get a call on the phone from my parents. I'd like either for them to be able to come and see him or for him to be able to see them.
That's a very sweet answer. Lisa, how about you?
I would love to play in an orchestra again, because at the moment you can't really play music and go to concerts and everything. And
what do you play?
Part of cello. And that's a nice alternative to philosophy. Spend some time on that, and at the moment this is all cut down to a minimum. So I'm looking forward to musical life becoming a reality again.
Well, that sounds lovely as well. And Zeke, where are you headed?
Well, I'm one of those grandparents. So I have a 2-month-old, my fourth grandchild is 2 months old, and all the other ones I want to see as well. And so I think that's a top priority. And my mother is 86, and I would like to see my mother also. And I think this just emphasizes how social people are and how much the deprivation of COVID-19 has really been on our social interaction, and how desperate people. I just watched, the moment you open up restaurants or bars, they're flooded. Why are they flooded? Because people are social and they really want to get together with other people. We're no different.
Well, thanks so much for joining me. I hope this all gets figured out as soon as possible, so we can get out to restaurants and see our grandchildren. For those of you watching, that was Zeke Emanuel, Govind Prasad, and Lisa Herzog on their article, An Ethical Framework for Global Vaccine Allocation. I think there's a motorcycle driving by. You can find that at sciencemag.org. I'm Colin O'Connor for AAAS. Thanks for watching.